Hi, hello, and a very good afternoon. Optic nerve glioma and optic nerve sheath meningioma. So, are these tumors a clinical radiological diagnosis? If so, why is it still a diagnostic difficulty? Let's find out. Optic nerve gliomas comprise 1% of the intracranial tumors and meningiomas 1% of all the meningiomas. Still, optic nerve glioma is the most common optic nerve tumor and meningioma follows that. It's a diagnostic difficulty because the first reason, rarity of the disease, and the second thing being usually getting misdiagnosed as optic neuritis, thereby leading to all the problems as listed on your screen. So we analyzed retrospectively 36 optic nerve tumors, 15 gliomas, 21 meningiomas for the following. The mean age was 15 years among the glioma patients with 53% males and 43 years in the meningioma group with 57% being females. The main clinical features were mostly common: protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, disc changes. However, normal disc was seen in 13% of patients, followed by mild pallor, severe disc pallor, hyperemia, optociliary shunts, and choroidal folds. The mean duration of symptoms among the glioma patients was 52 months and 73 months among the optic nerve sheath meningioma patients, and most of them had protrusion of the eye and diminution of vision. The appropriate imaging in optic nerve tumors is MRI brain and orbits, plain and contrast. On your left side, glioma demonstrated by the enlargement of the nerve itself, hypointense on T1. However, a soft tissue mass along the nerve sheath on your right side, hypointense on T1, is suggestive of meningioma. In T2 weighted images, glioma displays high signal intensity and is definitely hyperintense, whereas meningioma can be iso to hypointense. Contrast enhancement seen in both the tumors: gliomas usually irregular and botchy, whereas meningiomas regular circumferential with a centrally non-enhancing optic nerve.
Okay, the timer is not there.
The two classic radiological signs in meningioma are the tram track sign in axial cuts, and in the coronal cuts it's the donut sign. So the patterns are tubular, globular, and fusiform. Fusiform usually gets confused with the glioma. Type 2 being with extension to the optic canal and supraorbital fissure, whereas type 3 being intracranial extension. Treatment strategies among the gliomas: chemotherapy was given in 7%, usually under 3 years age group, whereas 67% radiation. Among the meningioma patients, radiation was given in 95%. Incisional biopsy and debulking required only in few ambiguous cases. So how do we give EBRT? Usually, the T1 weighted axial and coronal images are registered with the planning CT. The gross tumor volume, which is the area of contrast enhancement, the area of tumor, of course. When this is expanded by 1 centimeter in all the directions, we get the planning target volume. Target specific radiation, as on the first image, 95% prescribed dose of radiation goes to the area of interest, followed by 50% to the surrounding area, and then 20% to the further area, thereby preventing collateral damage. So let's have a look at patients who had excellent response with improvement in their visual acuity and also reduction in the glioma as well as meningioma size following EBRT. So our study stands out from the others in the way that optic nerve glioma and meningiomas were analyzed, however separately. Diminution of vision and proptosis were the main clinical features in both the groups. MRI brain with orbits with contrast enhancement was done in 100% in either group. However, EBRT was the mainstay of treatment, and both the group of patients had excellent, stable or good visual outcome. So yes, both optic nerve gliomas and meningiomas are diagnosed clinico-radiologically, restricting surgical intervention only to cases of disfiguring proptosis and intracranial extension. Early diagnosis with fundus examination, correct requisition of MRI, precision reporting, and earlier access to neuro-ophthalmologists, ocular oncologists, accurate treatment with EBRT, thereby will lead to better visual outcome or stability. Thanks a lot.
So,
In our study, 27% had neurofibromatosis. The rest were not associated, sir.
Did you see in the neurofibromatosis, the secondary choroidal hematomas, and what were the iris findings? Did you see them?
Yes, sir, those were analyzed, but due to lack of time, I didn't put it here.
How many of them had lesion nodules?
Leash nodules were found in almost 50% of whomever had neurofibromatosis changes.
So one of the important things about the way of optic nerve is the axial proptosis and the early visual loss. That is one of the most common manifestations.
So in fact, that is the
Also, in
question.
neurofibromatosis, you get enlarged corneal nerves. It's one of the important causes of enlarged corneal nerves.
Yes, sir.
See, the presentation is sometimes very similar, and the outcomes also, as we've seen, tend to be similar. So what
Yes.
was the need to differentiate between the two? And the need to differentiate is what was just being discussed, that because gliomas will have separate associations that you want to be looking at, definitely.
Yes, sir. So the basis was not to compare either, but the optic nerve tumors usually can be a diagnostic difficulty, mostly getting diagnosed as optic neuritis, thereby leading to various inappropriate investigations and steroid treatment, and then getting referred as an optic nerve tumor. So the idea was not to compare
Yeah, but if you
glioma.
analyze that as well, no? To see that why does it matter? Why do we need to know?
Okay.
That's also important. Okay.
What was the percentage of opticociliary shunts in meningiomas
We found almost 15 to 17%.
out of your 27 patients?
Yes, sir.